hard to see. I've showed this one yesterday, and there's the P wave at the end of the T wave. This is 2 to 1. It's a left bundle. It's probably distal block. Likely distal block. Here's one of the ones that'll get you. And there is a clue here. So here I see 2 to 1 conduction, 2 to 1 block, P wave. There's the second P wave. You can see it in the T wave here. 2 to 1 block. The QRS is wide-ish, but look, this PR interval of the conducted beat is very long. It's about 320 milliseconds. If you think about it, distal block should never have such a long PR interval because this delay would all have to be below the His, and you never see HV intervals of 200 and something. So this is probably proximal block, even though the QRS is wide-ish. And if you wait a little later on, this same patient ends up with 3 to 2 Wenke-Back conduction, typical for proximal block, typical Wenke-Back periodicity. And this one, again, with a right bundle branch block, has a long PR interval and an inferior infarct. So even though it's right bundle branch block, this is proximal block. This is AV nodal block. This will recover and does not require pacing. So not all blocks are AV block. You can have, this case I'll just quickly, this is SA block. And we can see here it's slowed down. So this is actually 2 to 1, 1 to 1 with some occasional block beats, and ultimately 2 to 1 SA conduction. And there it is there. And lastly, the last ECG I'm going to show you is a complex block, not dissociated, because we see that the QRSs are irregular, atrial flutter. And when I count out the P waves, I see that the ratio is 8 to 3. So those of you who like mathematics are going to have a lot of fun with this, because Wenke-Back block is always n plus 1 to n. P waves to QRSs, input to output, we'll call it. N plus 1 to n. So this is 8 to 3. So it's 2-level block, 4 to 3 and 2 to 1. So if you take 4 to 3 and 2 to 1, you end up with 8 to 3. So always be thinking for 2-level block, if you see a very complex pattern, it could be 2-level block with Wenke-Back at one level and 2 to 1 block at the other level. So if you have Wenke-Back plus 2 to 1, you end up with 8 to 3. This is a lot of fun to kind of work those things out. So AV dissociation and heart block are associated terms, but they are not they're not the same. They're different, but they may be associated. So I want to thank you for your attention. I know that was complex, but I went over my time by 2 minutes. Thank you.
Thank you, Dr. Martin, for an excellent deliberation. I'm sure all of you agree that he has made this complex topic look very simple to all of us. If there are any questions, feel free to ask Dr. Martin. Yeah.
So the question, I don't know if everyone could hear, has to do with left anterior hemiblock, right bundle branch block, and a prolonged PR interval, which some people will call trifascicular disease or trifascicular block. You know, that's clearly distal block. The problem with it is that the real key point in that type of conduction disturbance is, do they have symptoms or not? Because if they are asymptomatic, the progression to complete heart block is actually relatively low. It's in the neighborhood of 1% per year. Whereas in symptomatic patients, if a person has syncope and no other cause for syncope, with that ECG, I would say they need pacing. But it's really a function of do they have symptoms or not. Thank you.
Dr. Martin? In 2 to 1 AV blocks with a narrow QRS escape rhythm, you would expect it to be a Hisian escape. But is it possible for someone to have a 2 to 1 AV block with a narrow QRS complex and you find on EP study that the disease is actually confined to the distal conduction system. Is that possible?
So let me just try to get into the terminology a bit. Because if it's 2-to-1 conduction, they're not escape beats, they're conducted beats. When I use the term escape beats, I'm talking about beats that originate below the conduction system because of block. So if you have 2-to-1 block with a narrow QRS, could that be proximal or distal? Well, the answer is it could be either. If it's a narrow QRS, it will almost always be proximal. The reason I say almost is because you can occasionally have delay in both the right and left bundles that's simultaneous that can give you a narrowish QRS. It's extremely unusual. So generally, if you see 2-to-1 conduction with a narrow QRS, the block will be AV nodal, not distal.
Hello, Dr. Martin? Yeah. You showed one slide where there is a patient with atrial flutter with 4:1 block. And the atrial rhythm was regular, ventricular rhythm was regular. And do you think there is a complete heart block? Because
No.
atria is listening to the ventricles there.
No. There were 2 ECGs with, do you want me to go back on them?
Yeah.
Because I think it's a critically important issue. Where do I find this now? I've gone off my, here we go. Okay, hold on. I showed 2 ECGs that looked almost the same, but were actually quite different. So the first one is atrial flutter. The atrial rhythm is regular, the ventricular rhythm is regular, but each flutter wave has a constant relationship with the subsequent QRS. So that is 4-to-1 conduction, not dissociation. They are associated. The next one I showed, and this is the critical difference, is atrial flutter in the atrium with a regular ventricular rhythm, but the relationship between A and V is not constant. If there's conduction and they're both regular, there must be a constant relationship. If the relationship is not constant, it cannot be conducted. So now I'm going to look here. I see this flutter wave, and I compare it to this QRS. And now I look here, and it's different. So once I've established that both the atrial and ventricular rhythms are regular, I look to see if the relationship between each atrial activation and each ventricular activation is constant. If it is not constant, then they are independent. So this is AV dissociated. This rhythm, this ventricular rhythm, is not conducted. That's the difference between this and the previous ECG, which is conducted. Does that answer your question?
Thank you, sir. I now request Dr. K.H. Srinivas to felicitate our speaker, Dr. Martin Green. And I request Dr. Martin Green to hand over the certificates to the chairpersons.
I invite the chairpersons for the next session. Dr. Ketan Mehta, private consultant in Mumbai, Asian Heart Institute, Sorplus Hospital, Dr. Ballabhai Navati Hospital, Seven Hills Hospital. Dr. Bhaira Reddy, Professor of Medicine, Rajarajeshwara Medical College, Bangalore. And Dr. Mabin, Professor and Head of Department of Medicine, AJIMS, Mangalore. Kindly take your seats. I invite our speaker, Dr. Narayan Nambudri, onto the dais to speak on 6 sinus syndrome, sinus node dysfunction, varied presentation and how to recognize it. I request the chairpersons to introduce Dr. Narayan Nambudri.
Good afternoon, everybody. The first session in the afternoon session, and we have none other than Dr. Narayan Nambudri, which of course is a well-known figure in of course this part of the country. He is the Associate Professor of Cardiology from Sri Chitra, Tirunal Institute for Medical Science and Technology, Trivandrum. He has done a fellowship in EPA from Australia. He is a section editor for Indian Pacing and Electrophysiology Journal, had a lot of publications in national and international journals, and he is also honorary secretary of Heart Rhythm Society Kerala chapter. So with these words, I would request Dr. Namundri to start on. He would be talking on sick sinus syndrome, sinus node dysfunction, varied presentation, and how to recognize it. Thank you.
Respected chairpersons, senior physicians and friends. It is not uncommon to see a patient with a sinus node dysfunction in general clinical practice. A typical patient presents with a history suggestive of cerebral hypoperfusion in terms of frequent pre-syncope, post-syncope, and an ECG, 12-lead ECG or a Holter which shows significant sinus pause or sinus arrest. But this can also present in many atypical forms. Let us start with a illustrative case. This 21-year-old medical student, a dental student, presented with a history of 3 episodes of syncope within a period of 6 months. Patient had a history of recent onset seizures prior to onset of these syncopal episodes and was on regular treatment for the same. No other neurological symptoms were noted during these transient loss of consciousness episodes. The electrocardiogram at the time of presentation showed sinus arrhythmia. A provisional diagnosis of symptomatic sick sinus syndrome was made. This was the Holter recording, a significant sinus pause of 3.3 seconds corresponding to the pre-syncopal episode. So this patient was admitted for a pacemaker, and while we copied the treatment records, we just noted this patient was on carbamazepine 600 milligram per day for seizures. This was immediately replaced with a lamotrigine. Carbamazepine is a sodium channel blocker which can affect the sinus automaticity, we know, and he has remained asymptomatic for the last 7 years. So sinus node dysfunction, sinus node is probably not the only culprit. In this talk, I will be discussing about what sick sinus syndrome or sinus node dysfunction is, what are the typical as well as atypical presentations of sick sinus syndrome, and how to evaluate a patient with a suspected sick sinus syndrome. We know sinus node contains 2 types of cells. One is responsible for the automaticity in form of P cells, pacemaking cells, and another set of cells called transitional cells which mediate the transmission of this impulse from the sinus node, that is a site of formation of the impulse, to the surrounding atrial tissue to result in P waves. So there could be 2 pathologies within the sinus node, that is inability of the P cells to produce an impulse which is called which results in sinus pause or sinus arrest, and the other one, that is impairment of transmission to the atrium resulting in sino-atrial exit block. If you take statistics based on the electrophysiological studies, sino-atrial exit block is much more common than impulse abnormalities in impulse formation. We know the pacemaker cells are characterized by particular channels called funny currents, funny channels, and also they have got a slow diastolic depolarization which can account for the automaticity specific to pacemaker cells. Apart from this sinus node automaticity, sino-atrial junction conduction as well as autonomic tone can result in various sinus arrhythmias or abnormalities of sinus node function. Sick sinus syndrome is a wide spectrum of group of disorders caused by a malfunctioning sinus node, which manifest in ECG as sinus bradycardia or sinus pauses, which could be sinus arrest or an exit block, a tachybrady syndrome, and chronotropic incompetence. We'll come to them one by one. And the burden of the problem, it is quite common in patients aged more than 50 years to the degree of 1 in 600, and it accounts for nearly 1/4 to half of pacemaker implants across the world. The commonest causes can be divided into intrinsic as well as extrinsic, and intrinsic ones are idiopathic and degenerative, and the extrinsic ones, we know clearly that hypothyroidism can result in sinus bradycardia, electrolyte imbalance can result, and similarly, situational syncopes can occur with associated, though they are not primarily sinus node abnormalities and not uncommon to see a patient with a carotid sinus hypersensitivity neurocardiogenic syncope. But probably the most important ones are related to drugs like antiarrhythmics, antihypertensives like beta blockers or non-dihydropyridine calcium channel blockers, SSRIs, very common prescription, and lithium, and as I mentioned, sodium channel blockers like amongst antiepileptics, carbamazepine, phenytoin, and sodium valproate. In the newer antihypertensives, clobazam, as well as lamotrigine, gabapentin, levetiracetam, they are all uncommon. They don't impair the sinus node function. I would like to mention that particular point. They present with a history suggestive of cerebral hypoperfusion varying from lightheadedness to syncope. This is a patient who presented with the EC fatigability, and the ECG had shown sinus bradycardia. As Dr. Green had already mentioned the degrees of AV blocks, even sinoatrial block can have varying degrees of conduction abnormalities. The type 1 is a delayed conduction, and type 2 is nothing but dropped, which also could have type 1, which is Wenckebacking, and type 2, where it results in sudden failure and high degree block and dissociation when you have abnormalities in sinoatrial conduction, totally dissociated. Unfortunately, in an AV block, you can see the atrium represented by the P wave and ventricle represented by the R wave. Here, the depolarization of the sinus node is not represented in the ECG. So when you have a prolongation of the conduction from the site of impulse formation to the atrium, it is not manifest in the surface ECG. So as third degree SA block, when you have dissociation between them, usually it presents as junctional rhythm and it cannot be diagnosed on surface ECG. On the other hand, if you have a sinus block rather than a sinus arrest or SA block rather than a sinus arrest or a sinus pause, we can infer the presence of this SA block while calculating the PP intervals. If it is the multiples of the basal PP interval, you should suspect a SA block because the automaticity continues on at regular PP interval, and once it gets blocked, only that particular beat is missed. And of course, grouping of beats would give clue to the second degree AV block. And in a type 1 second degree SA exit block, there is progressive shortening of the PP intervals till it beats from the sinus node fail to activate the atria. And type 2, it remains fixed till one gets blocked. There is no universally accepted definition to differentiate between sinus pause and sinus arrest, though when you have a significant prolongation, we call it sinus arrest. Apart from these typical presentations, we can have atypical presentations of sinus node dysfunction in many clinical settings. One important condition is in the setting of ischemia, when a patient has an inferior wall MI or secondary to drugs, as I showed in the illustrative case, and pauses at the termination of tachyarrhythmia. Patient presents with atrial fibrillation or atrial flutter, which probably remains asymptomatic. When the flutter or the fibrillation terminates, these patients present with a syncope due to the time taken for the sinus node to recover, which is already suppressed for a longer period of time. The longer the degree of suppression, duration of suppression or duration of the tachyarrhythmia, the longer would be the recovery time taken by the sinus node as well. And the tachybrady with the pauses. Another one, atrial flutter or fibrillation masking an underlying sinus node dysfunction. Patient comes for atrial flutter ablation. We ablate the atrial flutter and the patient goes back to, goes junction of bradycardia with no sinus escape, and they become more symptomatic and great masquerades like hypothyroidism. This 72-year-old lady with inferior wall MI, last week admitted to our ICU, post PCA to RCA, had stent thrombosis. PCA was done outside and was admitted with a stent thrombosis and recurrent, re-MI. It shows an atrial fibrillation with a fast ventricular rate. When the atrial fibrillation terminates, you can see a prolonged pause. AFib terminates here, a 10-second pause here. So what could be the cause? The contributing factors could be sinus node suppression related to atrial fibrillation. As I mentioned, the atrial fibrillation, there is a sustained atrial arrhythmia going on, sinus node gets suppressed, the funny channels gets down-regulated, and it takes longer time for the sinus node to recover. Second is the ischemia related to RCA involvement and sinus node ischemia and the drugs for atrial fibrillation. And after the termination, we put the patient on amiodarone 100 milligram per day and metoprolol. Last 5 days, no tachyarrhythmia and no subsequent bradyarrhythmia as well. So the contribution from the initial two might be more important than the third one. Sorry for the clarity. We can see this is an atrial flutter with a varying AV conduction. We can see the P waves here, and it shows a very low amplitude P waves. This patient had a fondant circulation, a lateral tunnel within the atrium. This is a scarred area, and extensive scarring of the sinus nodal region. We ablated and results in pause. This is another condition where the underlying sinus node is diseased, and at the time of discharge, patient is in junctional rhythm. We can have great masquerades like hypothyroidism, drugs I mentioned, carotid hypersensitivity, and athlete's heart. A 16-year-old boy with a dyspnea on exertion class 2 and pre-syncopal episodes. We can see the tachycardia going on, results in pauses at termination. And if you have a closer look, you can see the tachycardia terminating at the P wave. So it is not an atrial tachycardia. There is no reason for the atrial tachycardia to terminate the P wave. The last beat of the tachycardia gets blocked also in the AV node. Two unrelated events happening simultaneously. So it is not an atrial tachycardia. So there are some reentrant beats as well. So significant pauses. This was taken during a sustained phase of tachycardia. This turned out to be a PJRT, or permanent form of junctional reciprocating tachycardia. So coming to the evaluation of these patients, the goals of this evaluation is it's based on two important aspects. That is to confirm the diagnosis. For that, you need to show the relation between the sinus pause and the symptoms. The cause-effect relationship should be shown before we decide on further therapy, and to establish the etiology also if possible. There are many ways to demonstrate the pause. Routine ECG is a snapshot. You may or may not get any abnormalities with the P wave. In 24 ambulatory ECG, you may sample nearly 1 lakh beats.